Hello, everyone. It's a concerned doctor, and it's January 19th, 2022, and it's been a while since we've done a concerned doctor video. It's Dr. Miskoff, and tonight we're going to talk about an update on treatment because it's been an awful long time since we've done that. We've gone through, in the beginning of time here when COVID was first hitting, taking it all the way through the hospital treatments. The outpatient treatments were basically a bunch of vitamins early on with some maybe aspirin and IV infusions, of course. But things have really refined and fairly recently as the variants for COVID-19 have progressed. As we know, the numbers have spiked in the last few weeks, and this is both in patients who are vaccinated and those who are unvaccinated. We are seeing substantial cases of COVID-19 in the vaccinated. I don't want to be misunderstood that I said don't get vaccinated. That's not what I said. Just simply that getting the vaccine does not necessarily protect you from getting the virus. It may, in fact, reduce severity. We believe we've seen, less severe cases. Certainly, the majority of the respiratory failures out there, are unvaccinated, or I should say old vaccinated, not meaning that they are old, but they haven't been vaccinated in a long time. If somebody had a vaccine over a year ago, one could argue that they're not vaccinated, right? Because if you had the flu shot in 2019 and then you waited till 2021, most would consider you unvaccinated for flu in 2021 before you went and got another shot. So at what point in time does somebody who received the vaccine actually be considered unvaccinated? That's a good question, and I don't know if I can answer that right this second. I think for all the other vaccines, it's a little bit more well-defined. So there are monoclonal antibodies. We've certainly in the past have done segments on taking an IV infusion in an ER if you in fact contract COVID. Sotrovimab is the newest and grooviest monoclonal that you can get in a lot of ERs throughout the country. It is restricted to those who are immunocompromised, and they do give preference to patients who are unvaccinated. So it doesn't mean that if you got a doc or a healthcare provider who has the ability to communicate with ERs that you can't get that borderline case through, but there are fairly strict, or stringent guidelines that these ERs are trying to follow, and rightfully so. They don't want to just give it out to everybody. And especially now that we have two new oral agents, Paxlovid, which is a double antiviral, meaning that you get an older drug that was actually used for HIV and mixed with the Pfizer oral antiviral, and it's 3 pills twice a day. You get 2 from the Pfizer pack, the Pfizer pill, and then one which is an older HIV drug. Very effective in reducing hospitalizations and death with COVID-19. In fact, I saw statistics earlier of up to 90% reduction. The earlier you get it, the better. It does have some significant drug-to-drug interactions that you need to have your prescribing clinician look at and be aware of, or the pharmacy cross-reference. But there are certain medications that if you are on them, the concentration of the medication could be increased or decreased. So something to be aware of. It is, it can have some GI side effects as well, of course. And then Merck's product is also a pill, an antiviral, molnupiravir, recently available. Just so you know, both of these I've been able to write coming out of about 2 or 3 different Walgreens pharmacies in New Jersey. I actually helped a friend of the family get Paxlovid in upstate New York yesterday at a Walgreens. So Walgreens seems to have the go or the connection rather to get the oral antivirals. So I've had success with that. I disagree with the concept of not writing the medicine because it's brand new and we don't understand it well enough. Look, if you're a high risk patient and you're coming down with COVID, I say as long as you have close monitoring by the clinician and communication with the clinician, preferably on a daily basis while you're going through COVID, you don't only get the mental relief, but you have earlier access to treatment. Period. So early access, getting these drugs or medications in you within 5 days of symptoms is key, whether it be the monoclonal, IV infusions, Trovimab, the Paxlovid Pfizer product, or the Molnupiravir oral agent. These are the newest medications that are available to treat COVID. Probably, I think, you look back at this video in a year, and they will likely push to get the oral agents, maybe even the monoclonal antibodies. There's already some of that going on in clinical trials for those who are exposed, just like Tamiflu or Xofluza for the flu. With Tamiflu, if you get exposed, you can take a half dose in prophylaxis to prevent it. I think we'll see those clinical trials published as far as prophylaxis for high-risk exposures coming. And, probably in a year or two, somebody says, hey, I got exposed to COVID. You could actually write the medication at a maybe reduced dose or maybe the same dose. We'll see what happens with the trials, but I wouldn't be surprised if we see that down the road. So that's the update on COVID-19 at Concerned Doctors Back. We're doing a little series here of videos, hopefully, keeping it to COVID for now because it's still a topic of concern, obviously. And now that we have oral agents, I encourage our colleagues out there to write them for the appropriate patients, of course, with normal safety concerns and following the PI. But these are, look, you got a pill that's more effective or more effective than the monoclonal antibody treatment now. Granted, the monoclonal antibodies have been tremendously successful if given early and well tolerated. They're not as always easy to access. So there are ways of getting these pills to the patient early. So reach out to your clinician if you test positive and get early detection and early treatment. Everybody have a good night.